Penn State Worry Questionnaire. The Penn State Worry Questionnaire (PSWQ) is a 16-item trait measure that assesses the propensity to worry as well as the intensity of worry experiences without reference to specific worry topics. The items are rated on a 5-point Likert scale from 1, not at all typical, to 5, very typical, with items 1, 3, 8, 10, and 11 reverse scored. Although there is some debate over the factorial structure of the PSWQ, only the total score is normally interpreted. The PSWQ has high internal consistency, test-retest reliability, and correlates with other self-report worry measures, but it does have lower convergence with measures of general anxiety. Group comparisons indicate that individuals with GAD score highest on the PSWQ, followed by other anxiety disorder groups and major depression who have similar elevated scores that are significantly higher than non-clinical controls. A PSWQ cutoff score of 45 can be used to identify pathological worry or GAD in a treatment-seeking population, although a higher cutoff score, 62 or even 65, is needed to differentiate GAD from other anxiety disorders and possibly even depression. Daily mood rating. In clinical practice, daily idiographic ratings of general anxiety level can be a very useful metric for tracking fluctuations in subjective anxiety. For example, Krask and Barlow suggest that individuals complete a daily mood record in which overall anxiety, maximum anxiety, overall physical tension, and preoccupation with worry are rated on a 0 to 10 scale at the end of each day. This can be augmented with single ratings on more specific symptom dimensions that may be more indicative of the person's particular anxiety disorder, such as ratings on average worry about having a panic attack and panic disorder, or mean daily social evaluative anxiety and social phobia. It is important that the cognitive therapist also assess changes in general anxiety as part of an evaluation of treatment effectiveness and for identifying situations that trigger anxiety. These data can be useful for suggesting issues that need to be addressed in therapy. Beck Depression Inventory 2. The Beck Depression Inventory 2, BDI-2, is a 21-item questionnaire that assesses the severity of cognitive, affective, behavioral, and somatic symptoms of depression over a 2-week interval. The BDI-2 is the third and latest revision of the original BDI that was published by Beck, Ward, Mendelsohn, Mock, and Arbo. The second revision of the BDI has been used widely in depression research, and so most of the psychometric information has been generated on that measure. However, the BDI and BDI-2 are highly correlated, so the psychometric findings on the BDI are relevant for BDI-2. Although the BDI appears to be multifactorial, the total score is most often used in clinical practice and research. There is extensive research demonstrating the internal reliability and the convergent and discriminant validity of the BDI. Individuals with major depression score significantly higher than those with anxiety disorders. The cutoff scores of the BDI-2 are 0 to 13 non-depressed, 14 to 19 mildly depressed or dysphoric, 20 to 28 moderately depressed, and 29 to 63 severely depressed. Given the high co-occurrence of depressive symptoms and disorder in those with high anxiety, it is recommended that the BDI-2 be included in the standard assessment battery for anxiety. The BDI-2 is available from Pearson Assessment at pearsonassess.com. Fear activation, assessment, and formulation. Experimental research on the immediate fear response uses information processing tasks and psychophysiological measures that are not readily available to the therapist. However, the practitioner can use self-report, interview, and behavioral observation methods that rely on conscious, effortful processing in a manner that offers valuable information on a person's immediate fear response. One of the most basic proportions of cognitive therapy is that schematic content, which is inaccessible to direct observation or detection, can be inferred from conscious verbal report of one's thoughts, images, daydreams, ruminations, evaluations, and the like. Beck stated the schemas pattern the stream of associations and ruminations as well as the cognitive responses to external stimuli. Hence, the notion of schemas is utilized to account for the repetitive themes in free associations, daydreams, ruminations, and dreams, as well as in the immediate reactions to environmental events. If schemas direct conscious thought, then the differential activation and content of schemas can be inferred from verbal content. Furthermore, there is a direct link between automatic and elaborative processes as indicated by evidence that changes in conscious appraisal or meaning can modify automatic threat biases, and that an automatic attentional bias can be induced through an attentional training program that involves both brief and long processing intervals. Together, these considerations lead to the following proposition: that the nature and function of automatic threat schema activation during the initial fear response can be determined from the cognitive, behavioral, and psychological products of this activation. What situations, cues, or experiences trigger the immediate fear response? What is the core schematic threat or danger to self? What is the immediate inhibitory or defensive response to this threat? Although standardized questionnaire and interview data can be helpful in building a case formulation, the most critical information will be obtained from ideographic measures. These are self-monitoring forms, rating scales, and diary records that allow the person to collect critical information when experiencing anxiety. They are tailored to the particular needs and circumstance of each client so that process-oriented online data gathering is available that contributes to a more accurate case conceptualization. Behavioral observation is another assessment approach that can provide important clinical information on immediate fear response. Some anxiety states, like social phobia, OCD, and PTSD, can be quite easily elicited in the therapy session by introducing relevant triggers of anxiety. Other anxiety disorders like panic and GAD require more ingenuity in order to trigger an immediate fear response. Often the therapist accompanies the client to particular external situations in order to observe an anxious state. In either case, direct observation of a fear response provides opportunity to gather detailed information on the nature, severity, and functional characteristics of the immediate fear response. We believe it is important for the therapist to have at least one opportunity to observe a client's acute anxiety state in order to develop an accurate case formulation and a sensitive, individually tailored treatment plan.